finally, Jakob is going to enlighten us on the treatment of brain abscess. And our first presenter, Dr. Crystal Bansal, we have to say congratulations to him, because today is the 4th of June, and I was told yesterday that the 4th of June is the Independence Day of India. And India is in fact a fantastic country. It's the biggest population in the world, even larger than China. And it's also the biggest democratic government we have in the world. And of course, it's different to be in India if you compare to Scandinavia. Also to work as a neurosurgeon. You don't have the same resources as we have, and also the people demography is different, because we have what we call a problem, the elderly population, which is a long name, but at least they have some special challenges. And in India, the majority of the population has an age that is below 30 years. So they have a different kind of population in the hospital, and they also have some different cases they have to work with. And I'm so pleased, Dr. Bansal, that you were able to come to Aalborg and not only tell us about the way you treat aneurysms, but also to give us a look into how it is to work as a neurosurgeon in India. So Dr. Bansal, welcome.
Here in front of you. I come from a different world where things are not same as in Scandinavia. 30 years or 35 years down the line before, my teacher used to say, when some SH patient comes in the hospital, they used to put him in the corner. Because nobody used to operate aneurysms around 35 years ago in the 90s and 80s. So if after 4 weeks or 6 weeks, if patient survives, then they operate, try to operate, and if doesn't survive, then it's okay. So when I was being trained, my teacher used to have very love with the aneurysms. In 2000, then when he used to operate aneurysms, the assistant professor has to operate, we open the skull, and we have to stand by there to see how he is operating. So just in the morning, we were trying to discuss with the needle or knife or clip or coil. So what to talk about while nowadays, very few centers, even in India, does coiling and all that. But clipping is still a more commonly being done. So after my training, I learned it myself from the different giants, visiting them in their hospitals, seeing them. So I come from a world famous pink city, because the whole wall city is painted pink since the beginning, and still it has to remain as a heritage city. And it has come in 3 or 4 years ago in the UNESCO World Heritage City. So we know how the aneurysm. How this meeting works. So we know how dreadful this disease is, and we see, and it's blast in the brain. So we know that in India, the healthcare is very much neglected. The first reason is because of the money. Many people have to pay it from the pocket. There is no government insurance, and the public hospitals doesn't have the whole armamentarium or the trained people to do and many things. What we call as toys like microscope and all the things they don't have. So the theme of the today, the conference Scandinavian Society, is the first do no harm. So the surgical intervention should not be worse than the natural progression of the disease. We should consider in mind every time. So I'll start my talk with the case capsule, how it happened. Like, this is a 42-year, not a hypertensive man, presented with a sudden severe headache. He was fully conscious, Glasgow was 50, no deficit, only negligibly. What we will do? He was done with the CT scan and he came to me with this CT. The CT shows, you know, that basal systems bleed in interhemisphere, but here you can judge that the more blood is in the right cerebral fissure. So there can be a right MC aneurysm or right IC aneurysm, or maybe a ecom aneurysm, which is more common. So what we will do next? We do not have the DSA. We have only CT angio. So we did the CT angio. So here you can see the aneurysm is here. So what is next? Coiling or clipping. So morning people were discussing about which patient should go to coil, which patient should go to clip. So the clipping and coiling, both the results are not the same in every syndrome. It depends on the skill, it depends on the patient. So there are two factors, the patient factor as well as the surgeon's factor also. So both are more important for the outcomes. So here in India also now we start discussing with the patient that what you want. You want clipping or coiling. So the patients, those who have money, they go for coiling because it's very expensive now, because they have to pay from pocket. So the clipping is a bit cheaper. So patient got agreed for coiling. So my endovascular colleague took him in the angio suite, and he, while navigating the catheter, he injured the aneurysm. The aneurysm got ruptured, the dye leaked into the subarachnoid space, the ECG got flattened, the asystole happened, patient was given CPR, both pupils got dilated, but finally he was revived in the angio suite. So what to do next? Anybody, any colleague? Tell me. Can you guide me? Like, what should we do now? My endovascular colleague called me from the angio suite. That patient is gone. Now it's yours. You take care of him. What you will do? How?
New CT scan.
Yes, please.
New CT scan.
I didn't got you.
A new scan. A new scan.
A new scan? Okay. This is the new scan. This was done immediately. I told my endovascular colleague to send this patient, and patient was under general anesthesia, send him to the CT scan, and the CT scan was this. Now what? What to do? Yes, please help me. Yes.
Excuse me, why did you say in a former slide that the aneurysm was not ruptured? It's obvious that it has ruptured.
What?
Got ruptured, sorry.
It's okay now.
Okay. So this was the CT. Now what to do? This is the comparison with the CT when he came to my office, and this is CT after the rupture of the aneurysmal wire. What to do now? No, the CT angio is already there. We have done it before. This is CT angio.
Is this pupils stay fixed?
Pupil was dilated at the time of rupture
But then like contracted or they were small or nothing?
because patient was under general anesthesia. So pupil was dilated and the CPR was given, but finally patient got revived. So now, this is compared with the first CT, now after the rupture. In the procedure, peri-procedural rupture, now what to do? Any suggestions, please?
If you want to continue treatment, then you might try to operate the patient.
Try to operate? Okay, I took him to the OR. I did the first cleanotomy, and the brain was firing angry red, swollen. Somehow, anyhow, I dissected the cerebral fissure, opened the cerebral fissure, and cleft the aneurysm, did the neuroplasty, kept the bone in the abdominal wall. So because I know my brain is going to swell like tomorrow, day after tomorrow, because of this high volume of subarachnoid hemorrhage, and it's going to irritate his brain. So I did the large trauma flap, large frontal right cleanotomy done, cerebral fissure opened, blood washed, aneurysm clipped. In every patient I opened lamina terminalis. In most of the aneurysms, the neuroplasty done and bone flap removed and covered in the abdominal wall. Now, what do you expect? Patient was shifted to intensive care. Although the patient's vitals started coming down to normalize, like pupil got normal, his respiration started coming, and so the next morning we did the CT. So you can see the clip is here, the CT, blood is still there and the bone is not there. So, but if you compare it with the after procedure, CT seems to be better. So next morning, we did the CT angio also to see the aneurysm was nicely clipped and there is no distal infarct, there is nothing, no vessel injury distal to the aneurysm. Both A2 filling nicely as before. So we planned to extubate the patient and the patient got extubated next morning with no sepsis. And after 4 weeks or 6 weeks, we put the bone back, and this is now 6 years. He is running a sweet shop and still he is sitting on the shop, enjoying his job. So I was with Juha in Helsinki a couple of years ago, before this surgery. So I saw him using adenosine, which he published, that with the adenosine you can make the transient asystole. So in case of intraoperative rupture, you can inject the adenosine, the anesthetist will put it, and the heart will slow down. So the film will be clear and you can. So this is similar to that. After the patient becomes all right, on one night I was thinking and conceived the idea of why not the adenosine is being secreted at the time of intraprocedural ruptures from our body itself. The nature releases the adenosine in our body. So I gave the concept and I sent it to the British Journal of Neurosurgery for publication, the transient reactionary physiological asystole, or I call it TRAP phenomena. It is the cause of fall or loss of consciousness after subarachnoid hemorrhage. So when I sent this to the editor, and he sent me immediately that I want to publish this, now only you make the English correction. So my English is very poor. We corrected it, and still he was not satisfied with the English. Then the editor sent me corrected version and he said that if you like it, you upload it. Now I will publish it. So this was a long story, and this I gave this term. So because we know that it's, the half-life of the adenosine is very, very low, only 5-7 seconds. So if patient develops subarachnoid hemorrhage and the adenosine is released from the body itself, and it by the time you take the sample, it's already gone. So there is very low possibility of. But after that, it has been cited at many times in many literature publications. So it's, I say it's not the mountains we conquer, it's we conquer ourselves. So the most important thing now I will talk about the aneurysms, why the aneurysm develops. The most important thing is the wall enhancement, which is this is a very good article. If you do this study, the wall enhancement remains significant predictor of wall tension while accounting for the effects of aneurysm size. And in a qualitative comparison, low wall tension areas are concentrated around the aneurysm blast. So when there is an aneurysm, I will show you more studies where it becomes more clear. So we know the Rotten's rule. The most important is that how the aneurysm develops. They arise at the branching sites of the carotid artery. The aneurysms arises, it turns or curves in the outer wall. The aneurysm points in the direction that blood would have gone if the curve at the aneurysm site was not present. So it is called the silent killer because it is often very difficult to know that you have an aneurysm, and the first symptom may be only headache, and it can be the last symptom of your life. Many patients in our area, they have a warming leak, what we call as warming leak. The first week is very small bleed, and the patient ignores itself that it was a headache, like a normal headache, and then they forget it, and then next time when the time comes, the patient has bigger bleed and it comes to us in very poor shape. So how we can avoid the mortality rate in aneurysm ruptures. So the Finland and Japan have the highest incidence of subarachnoid hemorrhage in the worldwide. Incidence of subarachnoid hemorrhage in Japan is about 15.4 to 22% per 1,000 per 100,000 people. The incidence in Finland decreased now after the smoking rate has decreased, but it is still high in Japan. The unruptured cerebral aneurysms are 2.8 times more likely to rupture in Japanese population than Finland population. So this is very important data, that if a Finnish person has a aneurysm, still the chances are less. I have worked in Japan in the special southern southeast area of the Japan near Nagoya, where they has to do the general screening of the people, and if they found an incidental aneurysm, they clip. I have seen them clipping incidental aneurysm by finding the screening of the society. So that is why they clip, because if somebody has aneurysm, the chances are more to rupture in Japanese population. So the screening of the society is common in Japan. So the clipping of incidental aneurysm is also there. So this is in the same area from where this study is for the UCAS study is the biomechanical consideration in the unruptured cerebral aneurysm study, the rupture risk, the wall rupture index they have told in this study. This is very good study. I would say everybody to read this study. And when an unruptured aneurysm is found, deciding whether to operate or follow up is one of the most important issues. If it is an incidental, what should we do? We did the screening, we found the aneurysm, now what to do? If we tell somebody that you have this thing, but he said that I don't have any problem. Why are you opening my skull? Why are you putting wire on me? I don't want. So there are guidelines for making the best final decisions on the treatment, taking into account the effectiveness of diagnostic and therapeutic devices, the risk-benefit ratio patients. As one of the rupture risk indicators, there is hazard risk ratio also, which is derived by the UCAS study in Japan research group, based on the method of around 7,000 aneurysms in 5,700 patients with aneurysms of 3 mm or more. So this is the rupture index. As the size increases, you can see the rupture hazard ratio and the annual rupture rate increases from, if the size is 3 to 4 mm and if size is more than 25 mm, the hazard ratio goes from 1 to 76 times higher. And the annual rupture risk rate is from 0.36 goes to 33, it's almost 100 times. So as aneurysm grows in size, the risk of rupture is very high. You can see there is a linear curve which is showing the hazard risk ratio is that what I told in the previous slide. It's all the same. So the true stress on the artery wall, as the stress increases, the chances of rupture is becoming more and more. So the rupture risk assessment based on the biomechanics, as the unruptured aneurysm expands, the wall thickness decreases. So the hazard risk ratio of UCAS corresponds to the stress of the aneurysm wall. So this is the annual rupture rate, and the chances of daughter secret is also more. So now there is one more case. A 50-year-old man was going on the bike to some place in the city, my city, and he had a headache. His son-in-law is a radiotherapist in the university hospital. So he himself told him that I have a brain hemorrhage due to sudden severe headache. So then he requested that my CT scan should be done. So he got what he suspected. So this was his CT scan when he came to me. So going on the bike, sitting on the pillion rider, and this was the aneurysm he got. So I clipped this aneurysm. You can see the optic nerve, and this is the right side A1, and the aneurysm is long segment like this, so it's anterior-inferiorly pointing. Can you forward the video? Chance. So when I was with Juha, after the surgery, he used to sit with us in OR and he used to tell us how you can tackle with the aneurysms, how you can be cool. Because in one of my institute, when there was an aneurysm, every resident and every assistant professor in the faculty has to be on toes, that any time it can rupture and he can shout on everybody. So people has to remain active with them all the armatorium. So, but he remained cool and he used to talk about. So there's a famous word by the Michelangelo, and he also conveyed all the time, Juha, that he paints with his brains and not with his hands. So before operating, we make a 3D picture, and I suggest all the residents to make a diagram of the aneurysm, whatever seen in the angiogram, and then design your brain according to the 3D picture you make it. So the half of the surgery you have already done in the night before you wake up. So in the morning, your half work is done. So I will speak something about the clipology, the clip design, type, strength, opening, closing pressure. Maybe most of you knows about that. So the comparative study is opening and closing pressure has been done, and which is the eponyms of the clips. You know that the name with the scientist or the doctors who has invented them. The opening pressure is the arterial pressure required to open the arterial aneurysm cleft. And their findings, they show the difference in closing pressure among the different brands. So when I was in Japan with Professor Suzuki, he used to tell that the Sugita clip is less smarter than the Yasaki clip. So the usual closing pressure of the aneurysm clips, these Yasaki clips, is from 108 to 201 grams, but usually it's around 151 to 180 grams closing pressure. So So there is another comparative study by Suzuki itself that the intracranial aneurysms about the physical endurance. So even if you open and close it 500 times, the closing force decreased only by 3 to 7%. So and you can re-sterilize it many times. Like if even after 17 hours or 100 sterilizing procedures, the closing force does not significantly decrease in the clefts. So basically small cleft reproduction, and then the Victor Horsley cleft the neck and packed the aneurysm. So the material most commonly is nowadays is titanium or the Phenox alloy, which is IMR compatible. And temporary clefts are specifically designed to occlude the vessels without applying enough pressures to cause arterial wall injury or dissection. So the closing pressure of the blade is less, about 1/3 of the pressure of the permanent cleft. So how many of us are using temporary clefts? Is it routine for everybody? Everybody uses. So what are the benefits and what are the disadvantages of using the aneurysm cleft? So if you have the chance, if you can see the parent artery easily and dissect it nicely, so I think I would not suggest to use temporary clefts, because temporary clefts sometimes can injure and can lead to infarct later on also. I have burned my finger sometimes. So although it reduces the risk of massive blood loss and obscuration of the operative field in the event of rupture, but it's better to avoid in old people when the arteries are atherosclerotic. Do you want me to stop now? Really? Okay, thank you. So kind of you. So we know how the clefts are evoluted from the 1968 to 1995. So if you know, the American actress Sharon Stone has told that if you act like you know what you are doing, you can do anything bloody in the world, but not neurosurgery. So your work is carved out of the agony as the statue is carved out of the marble. Because when I was a resident, I was very horrified by the aneurysm surgery, and when I started doing it, and now I am, for last 10 years, I'm enjoying it and I'm relaxing it. This surgery is relaxing for me. So this depends on how you take the things in your, because we have no much experience in our this thing. So we both things happen. So there is so many and this patient is a young lady who came to us with the bleed in the frontal lobe. So the patient was kept in some remote areas. When she came to me after 3-4 days, I thought this is not a place to bleed for a young lady. So there must be something else. So I did the angiogram and I found the distal intercerebral artery aneurysm. So we cleft it, and I usually make the diagram before starting the surgery, and if there is found anything else, I make it correct that I was wrong or right. So this is for me, and for every time when I operate, I see my videos 5 times, 10 times to see that how I am acting, my hands are working. So it is for learning myself. So this is another aneurysm without subarachnoid hemorrhage. So there is a subarachnoid hemorrhage without aneurysm also. So same things happens. So this is the aneurysm which is of unusual location, like it's near the anterior carotid artery. In these kind of patients, we develop cardiac nucleus infarct sometimes if we cleft this aneurysm here. And this was nicely cleft, and she has both the intraventricular bleed, subarachnoid hemorrhage, and the intraparenchymal bleed also, all the 3 things. So the major reason behind the development of aneurysm is the blood pressure raise. So if it has been studied in an environment for the nuns where the blood pressure in the women over 20 years may be avoided by living in a stress-free monastic environment characterized by silence, meditation, and isolation of the society. So, but the basic mechanism is still not known. There is another patient with intraventricular bleed and parenchymal bleed. This became the cast when I operated, the IC, this intraventricular bleed was not able to remove. This was a big aneurysm, large neck aneurysm. So I'm not going to show in the videos. That's all. Should I finish it now? Okay. Thank you very much.
Thank you. I have to say that I attended a meeting last year in Jaipur. It was a fantastic meeting for the Neurotrauma Society, which Dr. Bansal is the head of. And I was amazed that you could do so much for so many people with the resources and the possibilities you had. I was also a little bit amazed about the way that you kept the time. I remember that one day we were supposed to end at 6 o'clock and the meeting ended at 8 or 9. So here in Denmark, people like to have the lunch. So that's why we will cut off your speech. But thank you for this very interesting view into aneurysm. And in the lunch break, I will introduce you to Dr. Christian Halland, because he told me at Baitu this year that when he do aneurysms, sometimes he do the aneurysm surgery with the use of the Aneurysm and make the heart stops.